So, good morning, everyone. We have a very special guest with us today, Professor Dennis Culhane from the University of Pennsylvania, to talk about a very important topic in the UK currently, the prevention turn. What can we do to catalyse a turn towards prevention? Now, in the UK, we have such a proud history of being good at preventing homelessness in particular. We have some of the strongest legislation in the world, some of the best results. And yet, in the last 10 years, there's been a general trend in terms of spend towards spending less on early intervention and more on homelessness services. Now, this is why with the new government in place and with a new strategy around the corner, it feels like a really important moment in history to ensure that the trend is discontinued, so to speak. So I wonder whether we could start, Dennis, by talking about how similar those trends are or otherwise in the US. And of course, Dennis's work has touched on homelessness policy and research, not just in the US, but across the globe. So really keen to start with your reflections as to these overall trends and why they matter so much.
Well, so I think that if you look not at the last 2 years, we had big increases in homelessness the last 2 years, which was almost entirely driven by the migration crisis, where you have a lot of people coming into the United States through the southern border, and they were sent to particular cities called sanctuary cities by the governor of Texas. So almost about 200,000 people were sent all over the United States, and that they went into the homeless assistance program. So our numbers went way up the last couple of years. But prior to that, we were on an almost 15-year steady decline in homelessness, going down about 1 or 2% a year since around 2010. And that was because we completely changed the design of our system in 2009. We passed a law called the Hearth Act, which reauthorized our McKinney funding, the federal funding, and it put Housing First as the national strategy. And Housing First is not like this Sam Zimberis Pathways program. That's a program of Housing First, but the policy was prevention, rapid rehousing, and supported housing for chronically homeless people. So housing-led interventions, that's where they wanted the federal money to go. And so we had a 35% decline in family homelessness. We had a 55% decline in veteran homelessness. Those were two big priority populations. And that pretty much accounts for what the overall trend line. Now, meanwhile, of course, the West Coast homelessness problem is going out of control from about 2015 onwards. So the fact that homelessness was going down across the country, yet going up at double-digit rates on the West Coast, means that we really were having even more success than we might otherwise have been able to measure because of the big numbers increasing on the West Coast. So I think that the policy framework was to essentially convert from spending most of the federal money, used to go for emergency services. It used to go for especially the support services inside shelters. So not so much on the shelters themselves, but all the case management and other things that went in there. But when we converted most of those resources to housing programs, prevention, rapid rehousing, and supported housing, we had significant success. So I think that we saw evidence that we could make a difference by reorienting the whole way we looked at it.
And two things. So can you say a little bit more about rapid rehousing in case, people here don't know much about it, because the language sometimes means something different in the UK.
We think we stole the idea from the English, right? Because Hal Pawson wrote those two guides, one on prevention of homelessness and one on rehousing.
The housing options.
Yeah. So the two guidance documents that he wrote in 2003, I think they were. We pretty much stole those and repurposed them, and our whole concept of prevention and rapid rehousing was built off those documents, believe it or not. So
this is the housing options pathway, essentially.
And that was very useful for us. And we actually created our own version, authored our own version based on that. And we started in 2006 to pilot rapid rehousing. Now, we didn't really know how it was going to look. So it was like they say, you don't want to see how the sausage is made. the process of getting to a really solid program design took a while. But probably our best example, national standard of rapid rehousing is for the veterans program. We have a veterans program. And essentially, you can get first last month's rent and security deposit, so essentially move-in assistance to get out of homelessness. And you can get up to 2 years of rental assistance on top of that. It started out at 6 months, then it expanded to a year. But we found out that about 15–20% of the people still were not working and employed and making enough money. So a second year has been added for the roughly 20% people who still after a year are not on their own. But the idea is to get you out of, you've been dug into a hole, get you out, get you back on your feet, and with the expectation that you'll get employment and be able to pay your rent going forward. But of course, there's also connection to services. So there's a case manager who is assisting you with getting your housing, but also getting the health and behavioral health services you might need, and getting even some job training or coaching as well. So there's a package of services that the Veterans Administration also provides along with the housing assistance.
And in the US, there's been some evaluation of rapid rehousing.
Yes. And again, I say that the initial few years, the model was just so different all over the country. I don't know that the evaluations were very helpful because it's like apples and oranges and things.
Yeah.
But the veterans program has been evaluated very carefully. It's nationally standardized. The training is the same for everyone across the country. They even have a website which is called SSVF Library or University, SSVF University, because believe it or not, the acronym for the program is called Supportive Services to Veterans and Their Families. Now we think of it as it's our rapid rehousing program, but they didn't want the word housing in the title. There was some very particular, they wanted the word families in the title. So it's called SSVF, but there's a website, SSVF University, which has all the training materials there so there are a lot of standards that are applied to the program. And those evaluations have consistently shown that the program is effective. The people love the program. The workers, the staff who do the work, much prefer to do this work than they were doing with their shelter programs. So there's a lot of high satisfaction around the program. Politically, it's very popular in local communities because it funds nonprofits. So a lot of local political leadership. You really could not cut the program and its funding because the stakeholders are wide and very invested.
And just for UK colleagues, what's special about this iteration of this idea, really, that came from England, is that the focus is on bypassing temporary accommodation altogether. That's what's so special, and it's been evaluated properly, and the results are incredibly promising. So then is in the UK, the main pathway is still housing options, where people might go through something like rapid, that's closer to what you're describing, but a lot of the time, and this is what's pushing up costs, is that people are placed in very expensive types of TA. That again can be also harmful to those families as much as it being incredibly expensive. What would you say in terms of, given what you've learned in the US, is there a case over here? Because one of our priorities is to help local areas optimize those pathways anyway. But really, bypassing TA seems to be, it has worked in the US. What would be your tips?
So I would say that by the way the program is administered, it's actually the combination of prevention and rapid rehousing. It's bundled into one program. But by the administrative rule, 65% of the money must go to people who are in shelter, and 35% can be used on purely prevention, preventing people from coming in. Because if we didn't cap it at 35%, there was a belief, and I think a credible belief, that the money would all go to obviously admittedly needy families and individuals in the community, but they're not literally homeless. And the money would be going, and the evidence on that, which we can discuss, is that it's very hard to target prevention for people who are highly at risk for becoming homeless. Whereas for the people who are homeless, we have 100% success targeting because that's who we're trying to reach. And so the 65% has to be spent to get people out of shelter. So in that regard, it should be reducing the length of time people are in shelter. And so the cost per family in terms of emergency accommodation should be going down as more of the money is being spent to get them out. Okay, so that's sort of how we have dealt with that issue. And the number, the homeless families, the decline in homeless families since 2010, we think is largely driven by the fact that we no longer have transitional housing. Okay, that was by law. The Hearth Act really de-emphasizes transitional housing. It exists still some, but it was especially intended, let's reduce those stays, because people would stay for a year and a half, 2 years in those slots, and they're very expensive. Most places it's $50,000 to $60,000 a year. Places like New York, it's $100,000 a year for a family, so you're talking about very expensive. So the idea was to cut those down to a 60, 90 days period, during which they would get help finding another place, and then that whole package, move-in assistance, and then temporary rent for 6 months, but typically at least a year. So I don't know if that answered your question. But
well, over here we do have, it's slightly easier, the identification of people who might be at risk, because people can go to their local authority while they're at, before they become homeless for help. So I suppose the question is to what can be done with those families that doesn't involve, that step of very costly TA.
Exactly.
In your experience. Certainly your research very much showcases the fact that the best solution for everyone is normalized housing,
exactly.
as you call it. Can you say a little bit about that? Why just normal housing should be the default position?
Well, because what makes homelessness difficult for most people is the experience of having to be in these emergency accommodation programs. That's the thing that they most dislike. Yeah. It's the thing where they most experience the violations to their dignity, to their pride, to, they feel like they're under surveillance by these, guards or staff, whatever they might be. And, they feel like their children are vulnerable, or if they're single adults, they often feel like they can get victimized in these facilities. So being in these facilities is the problem. That's how people experience the problem of homelessness. Not just losing your house. Obviously, losing your home has one trauma. But the double trauma is when you have to live in these systems dependent on these charities that are very variable in quality and in the level of support that you might get there. So I think the main thing is we want to avoid having people to have to go into these places, right? If you or I lost our housing, or some kind of event happened, we would probably go to a hotel. We would access, in the U.S., we have private insurance for house loss and disaster, and you would get a temporary apartment until your house was fixed. So we don't go to a shelter. It'd be very unlikely. If you was with natural disaster, you might be in a shelter from FEMA, our emergency management agency, for like a few days, a couple weeks, but you would get out. And that's the point. We have to, the purpose of the emergency assistance is to get you out of these facilities, get you out of homelessness. That's what our job is. There's all sorts of other things. People have responsibility for your health, your behavioral health, your education, et cetera, but the homeless assistance programs, our focus should be getting you out of homelessness. That's our
Right, because the evidence really suggests that if people stay for certainly even a few months, it's damaging, no matter how good the services are.
That's
Even
right.
the services are good. After a certain point, certainly 2 years, very clear harm is happening.
Exactly.
No matter how good the service is, it's damaging you, it's institutionalizing you. And you've mentioned rapid rehousing. Obviously, the target group are people with lower support needs, people who haven't been in touch with the service.
Well, we actually have found, there was a recent evaluation in Los Angeles. So now Los Angeles doesn't call it rapid rehousing anymore. They call it time-limited subsidies, TLS, okay? Because it's not rapid. That's the main thing, is we call it rapid rehousing.
That's the goal, that's the goal.
But unfortunately, that's aspirational. It is not happening rapidly. It's usually taking like 3 to 6 months before people might get into a program, maybe even longer. So ideally, it should be happening in 30 to 60 days. Or 90 at most. but it doesn't work that way. Our supply in the program is too little. Like, we're not doing enough of this. That's another part of the conversation we should talk about, which is scalability, because it's great to have a good program idea, a successful program model, but if you can't scale it, you're not really going to be effective as a policy. And that's really where we are in our situation in the U.S. We have, on the one hand, the veterans program, which is scaled, and we have the non-veterans programs, which are not scaled. You know, only like 9 or 10% of people who experience homelessness are getting into either rapid rehousing or into supported housing, okay? 1 out of 10. You're not going to make progress that way. Whereas among veterans, we look at the chronically homeless veterans, we have more housing vouchers than we have chronically homeless veterans, okay? So we could theoretically house every single one of them, and 50% of them get into a unit within a year of being identified as having chronic homelessness. Rapid rehousing, 65% of the veterans are getting rapid rehousing. You know, again, it's compared to like 9 or 10% of the non-veterans. And we assume about 35% of the population self-resolves. They leave on their own within 30 to 60 days. So 65% coverage is pretty much saturation. So we have an example of scale and how it works. I mean, we cut veteran homelessness 55% in 8 years. But for the non-veteran population, the supply of these programs is way too low.
And in the UK, because obviously individuals have different rights, if you like, as opposed to it being about a particular program having a certain amount of money, the issues are slightly different. But this does bring us to the next topic I wanted to talk to you about. It's the whole government approach to addressing some of these issues, right? Because one of the big emphasis at the moment is the fact that the UK government is releasing a new strategy on all types of homelessness. So this is not just street homelessness, this is everyone. Okay. As you know, in the UK, that's in temporary accommodation is still deemed to be homeless, unlike the US. So in terms of, joined up approaches and systems level thinking and joined up across government, one of the big questions we're trying to help the government with is, in the UK, we often have the right policies, evidence-based policies. Implementing them in practice is a different matter. So what are the performance management systems at national, regional level in a context where the current government wants to give more power to metro mayors, for instance? What have you seen out there that works in relation to performance managed systems that are light touch but effective? And how do you combine that with targeted evaluation to continually drive results? Because even if something works, it could always work better.
Well, we've had some very successful programs that have targeted, piloted different efforts, but taking them to scale at a policy is another matter. So I think we still have the same challenge, but we have seen, especially when there have been particular communities that have taken on, like New York City under Mayor Bloomberg was very, very focused on trying to reduce inflow into the homeless assistance programs. And I think that one of the things we know is that about 25 to 30% of the people coming into homelessness are coming from a social welfare institution, okay? And those, the homelessness rates among people coming out of those institutions is very high. So whereas in the general community, it's very hard to predict who's going to become homeless. Obviously, people can come forth and say they would need assistance, as you mentioned, but most people don't know about those programs. They don't use the word homeless to describe themselves. They just find themselves lacking housing on an emergency basis, and the next thing you know, they're having to find out, well, what do I do about that? So, so trying to identify people in advance in the community at large turns out to be very hard. For every family or individual who comes into homeless assistance, there are 20 people like them who are just like them who don't come into homelessness. And predicting the 5% who come in versus the 95% who don't is very hard, because it's not just your background characteristics, it's very much about what's happening in your life at that moment. So we've done machine learning, we've done these things to try to predict who's at high risk. And you can predict that these people are going to have some homelessness, likely, very likely, but that's like in a 5-year period. You can't predict who's going to become homeless next month, okay? It's, you'd have to know more information about what's happening in their life at that moment, because it's very much a time-dependent circumstance, not just people's risk factors, okay? So that's challenging. Anyway, however, with this 25% who are coming out of institutions, we know where they are, we know who they are, and we know when they are coming out of these institutions. So number one is jail, in our case. The number one institution that most people come from is jail. The second one is detox. So people who've had a substance abuse emergency, they go into a detoxification facility, and their family doesn't want them home just yet, okay? And so they have nowhere to go, and so they end up in the homeless system. They're literally sent there. You know, here's the address, you go there. So that's a very large chunk. And then smaller but significant groups are people coming out of psychiatric hospitals, and we have folks who have emancipated from foster care in the last 5 years, let's say. So, but essentially, if you look at where did you come before you came into homelessness, about 1 out of every 3, 1 out of every 4 people is coming from one of those places. And we have very effective program models that can avoid homelessness for that group. And because their homelessness rates are so high, you know, 25, 30, 40%, you can have a lot of impact, and your targeting is a lot easier. And so I could say more about the program, but the one generalized program is called critical time intervention. I don't know if you've heard that expression, but the bulk of the evidence about the most effective program is critical time intervention. And the critical time being that if people are going to relapse into substance use, or they're going to relapse into, they're going to recommit a crime and go back to jail, or, you know, the people who return to jail or they become homeless, it usually happens in a very specific time period from their discharge. So that's the critical time period where you want to be intervening. And it's essentially a rapid rehousing program with more, you know, case management specific to those, the folks who are in those situations. So I would say that's our best evidence we have is CTI.
Yes, and certainly on our list of things we'd love to test formally in the UK, because they do exist in different forms, but, you know, actually formally doing a program that can be, have the type of evaluation that's evidence that you have in the US would
just
be.
in the last 2 years, I will tell you too, the interesting thing is, so our public health insurance program for low-income people is called Medicaid, okay? And it is the biggest expenditure, social welfare expenditure at the state level is that the federal government supports is Medicaid. And, you know, people have argued for a long time that homelessness constitutes a health emergency. It is one of those social determinants of one's health status that is bigger than all the other social determinants of health, okay? Because it bundles up so many challenges at once. So our states, some of our states, about 6 of them, have petitioned to the federal government to have permission to do basically CTI, critical time intervention, and to pay for it with Medicaid. And Medicaid has approved that. So you can now get housing navigation, case management, move-in assistance, and house setup expenses and rent up to 6 months. So they won't pay more than 6 months, because the goal was to try to get a year worth of rent, but they will pay up to 6 months rent. So that's a big breakthrough, that we now have 6 states that are getting money from the housing, or excuse me, from the health insurance agency to help people get out of homelessness or avoid homelessness. So that's something I think we can build on, and part of the reason we're excited about it is because it's an entitlement, okay? It's a federal entitlement. It does not rely upon appropriations from the Congress to, you know, be generous with the service. Like our homeless assistance funds is totally discretionary, and the government can fund it or not fund it, you know, whereas an entitlement, they're obliged to pay for it if you're provided with the service. So it doesn't quite work that evenly, I have to say, but that's the concept anyway. So getting homelessness prevention onto an entitlement program is pretty key. in my view, yeah.
Indeed, and as you know, we are lucky to have more entitlements for sure than in North America. But one thing we don't have that I'd be interested to hear your views on is the intergovernmental agency on homelessness and the role that it plays in terms of coordinating. I think it's up to 19 agencies in the US.
It was closed last week by the Trump administration. Yes.
Oh, there you are.
Yes. Elon Musk came through and they cut that program.
Yeah.
Yes.
So do you want to say something about?
But still, many states have their own version of it. So there are state interagency councils on homelessness as well, and you probably get more done at a state level because state agencies work more closely next to each other than at the federal government, where it's just a big policy machinery. So yeah, we have had the interagency council. It's helped to provide, guidance to states, and especially when we had Philip Mangano in that position, he was like proselytizing Housing First all over the country. So, depending on who sits in the seat and how they play the role, it's important. They provide some leadership. They don't have a real budget of any kind. They don't administer funds, but it has been important. But I would say I think that the state level interagency councils oftentimes probably have more impact because they can literally agency to agency, they can collaborate and coordinate programs and try to make sure that they're all working toward the same goal and not competing with each other with respect to some of these programs.
And is that the role they play? Can you say a little bit more about when they work and when they don't work? Because there's probably some variability as well when it comes to how they operate across the US. So what are the right conditions, I guess? Money.
If there's money on the table, it can work, right? Because if you have new funds, then you have something you can partner around. So when there have been initiatives to try to address chronic homelessness, we had some places like Utah, which were amazing, or Houston, has, is probably right now, a lot of people talk about the Houston success. They had a 60% decline in chronic homelessness over a 5-year period, and it was all around collaboration, kind of like the interagency council, but at a local level, okay, where the different agencies got together and teamed up around the different components of the intervention that they would take responsibility for, but that they would all prioritize these clients because recognizing that their situation was, again, a health emergency, and we need to address it like an emergency and not just say, oh, well, you can go wait for 8 months before we deal with this, I think that there have been examples like that, but usually it involves new resources that people can use, or pooling of some resources, because it's the resources that get people to work together.
The carrot and the stick.
Yes.
A couple of things I wanted to ask you about before we open up for quick questions from the floor. You know how we've talked before about the lack of opportunities to collaborate internationally, and in particular when it comes to challenges that specific cities face. So a city like London, where we are today, it has a lot more in common with other mega cities like New York than, frankly, anywhere else in the UK.
Right.
And certainly some of the trials that we're doing in the UK, it would make a lot of sense to do them across other mega cities or medium-sized cities, depending, and doing that work internationally. From what you've seen, what continue to be the barriers of being able to do those types of programs across cities in particular?
Well, the mechanism we have for that in our country is demonstration projects. And government can do certain things under demonstration authority where they don't have to do it for everyone. So, because one of the challenges, if you're going to try to do a program change, by law, you might have to be able to provide it to everybody who is eligible, let's say, or you would have to make it broadly available. Whereas under demonstration authority, you can do something for a smaller group of people, and because you're testing an idea, even though it could be quite a large demonstration. You could have several 100,000 people in a demonstration project, but you, under that authority, you're able to spend money specifically on that group without having to change the law. I don't know if you have that opportunity here or not, but that's how we typically will do big social change projects. It would be done under the demonstration authority. So you can do 5 cities, you could do 10 cities. We did, first of all, the Chronic Homeless Initiative from 2003 to 2008, $500 million was added to the budget to do about 60,000 funded apartments for chronically homeless people. That was big. And, but that was done, it was more like a demonstration project, if you will, than it was a real a federal policy. We've had a number of mental health related and substance abuse treatment related demonstration projects that have been effective. But again, the challenge is, yes, you can do that, you can prove that they work, but that's not a scalable authority. You'd have to change the legislation to make something more scalable.
And whether there's something to be learned by doing more work across certain types of city that have more common challenges.
True.
Yeah.
So, for example, this last year, there was a essentially demonstration project funding for encampments, okay? Because encampments have become an issue, not in every city, but particularly in the cities where they have very limited shelter supply.
Yeah.
Because we have everything from New York City, which has 5% of the homeless are unsheltered, to Los Angeles, where 75% of people are unsheltered. So we have huge variability with regard to what I would call shelter effort on the part of a given community. Some communities provide a lot of resources for shelter, and some provide very little. So there was a big demonstration project essentially funded last year. I think maybe 10 communities got money around dealing with encampments. So there have been efforts like that occasionally where it's understood that these are communities facing similar challenges, and let's try to get them some resources to pilot some projects.
Yeah, and Dennis, can you say a little bit about, because it's often, said that prevention can be potentially too expensive, which is why we end up spending so much money on managing issues. But in reality, if you look at the figures, managing a crisis can be really expensive, right? And we were talking earlier about how the shelter system in New York is $3 billion. Do you want to say a little bit more about quite how expensive this crisis systems can be?
You have to think about, well, how much is prevention? And in our case, I think most of what we see is that prevention costs around $1,000 per household, okay? That's the average amount. Some are getting several thousand, 3,000. Some people are getting less. But I think roughly on average, it's around $1,000 to $1,200 per case, okay? The cost of shelter on a national basis is right now around $30,000 per bed per year, okay? And then you have places where in New York City, it's more like $35,000 per bed. And if you're a family of 3, that's $100,000 a year. Okay, so it's hugely expensive. You could house 6, 7 families in an apartment for the whole year for the cost of one of those beds. Okay, so that's kind of the comparison of the cost. What's fascinating was that, we did this one randomized controlled trial experiment on prevention in New York City through the home-based program, which is the citywide homeless prevention, neighborhood-based homeless prevention program. And basically randomly assigned people to either get the cash plus case management versus not getting cash and case management. And what they learned was that the families who got the homeless assistance had half the homeless rate of the people who didn't get the prevention. But the difference was 8% of the people who didn't get any assistance became homeless, and 4% of the people who got the assistance. So you netted 4 percentage points from 4% to 8%. So you would think, well, either way, 92% of the people didn't become homeless, even if they got no assistance, okay? So is it worth it spending all that money for the 92 to benefit the 4 percentage points, right? Well, it turns out, because shelter is so expensive, that it actually was cheaper to give everybody the $1,000, okay, to reduce the 4 4% who didn't become homeless, because that 4%, the cost of shelter exceeded the cost of the whole program. So it was, I think, kind of ironic. People didn't
And that
expect
it does
that.
to society, right?
The cost, and that doesn't mention
yeah.
the cost of, I'm just talking
Yeah,
about the program cost.
exactly.
That the shelter cost, that it really turned out that giving $1,000 to everybody who's on the brink is actually cheaper than doing nothing and waiting for people just to show up into the homeless system.
Yeah.
So I thought that was a really striking lesson that came out from one study. Yeah.
Thank you so much, Dennis. And before we wrap up this part of the session, I'm going to open up to quick questions from the floor. Guillermo.
I'm fascinated to hear a bit more about the demonstration projects, and particularly how do we take them to scale? Because it's really useful to have a randomized control trial that proves a lot of evidence, or a demonstration project that shows that this is working. But maybe you can tell us a bit more about an example of a demonstration project that really got to scale. What were some of the conditions? What were some of the facilitators? And maybe what are some of the lessons that we can take?
Thank you, Guillermo. We'll take two more before we ask Dennis to answer because of time. Who else? Emily, Ray.
Yeah, thank you so much. I have kind of a lot of questions. Some specific ones. First of all, just out of personal curiosity, what were the 6 states that had that incorporation into the? If you don't know, it's okay. It's not a quiz.
You can definitely search.
Okay.
I know if you Google search, states that are doing Medicaid for homelessness, it'll pop up. There's a report about it that summarizes what each of those 6 states is doing. Actually,
I'm from Colorado, so I'm just nosy.
I'm not sure if Colorado's one. I know that Minnesota was one, and California is. Yeah.
My other question, and I'm hesitant to open up a whole can of worms here, but just in terms of talking about reductions, like you said, there was the 5-year massive reduction in Houston, and then obviously giant increases on the West Coast. I know there are a lot of factors that feed into that, but I'm curious about to what extent the numbers aren't necessarily reflective of whether systems are more supportive because of the immigration piece. So for example, in Colorado, in Denver, we have really good wraparound services for people experiencing homelessness, but we're having massive increases because we are somewhat of a sanctuary city, and so we have more people that we're accepting, whereas in Houston, it might not be the case that numbers are going down because services are better. It might be the case that numbers are going down because they're not accepting people who are migrating to the city.
Well, the period when Houston experienced that reduction was really before the migrant crisis of the last several years, because that really started in 2022. So that wouldn't necessarily, and there was a concerted focus on chronic homelessness at the time. So I think we can draw a relationship for that. Yes, with the migrant crisis, if you look at New York City, Massachusetts, Chicago, and Denver, they collectively account for almost 80% of the increase in homelessness in the United States over the last 2 years, because those were the places that the governor of Texas was sending people. So the number of homeless in Denver doubled. The number of homeless people in shelters in Chicago increased 5-fold. In New York City, it doubled. It went from 70,000 to 140,000 people on a given night. In Massachusetts, the number of homeless families doubled. So we're talking about really big increases that was really migrant-driven. And by the way, those are all declining now because the number of people coming across the borders declined. Families are being exited resettled into communities and jobs. So the numbers are declining rapidly as we speak this year in the 2025. So that's that part. But I guess the question about scalability, I mean, our Veterans Initiative is the only thing that's really scaled. And that was the political will. It was bipartisan. Both Democrats and Republicans wanted to be supportive of veterans. Veterans are perceived as people who, served their country. So there's a lot of patriotism around that. It's a politically popular issue. So I think you have to find what are the political opportunities for a group that could be perceived as, public support would follow. Personally, I think that in the United States right now, our biggest issue in homelessness is people who are elderly, aging, and people with disabilities. If you combine people with disabilities and older adults, you've got about 70% of the adult homeless population is either elderly or disabled. And we have, as a country, we have programs, 2 safety net programs that were created to prevent destitution among elderly and disabled people. One is our basic income program, supplemental security income. It was created in 1972 specifically for people who were elderly or disabled but did not have Social Security. They didn't pay into the Social Security system. Their disability, happened when they were young, so they didn't have time to contribute into the Social Security, or if they worked under the table. There's a whole group of people who aren't eligible for our main income support program for elderly and disabled people. It's about 8 million Americans are in this program, but it only pays $900 a month. Okay, it's been declining in its value against inflation, housing cost inflation specifically. It's been declining for several years. So now it's below what is the basic median rent for a 1-bedroom or efficiency apartment, and that's pretty new that it has overtaken 100% of the cost of the check. So I think that we could make a politically palatable argument that we should be providing basic assistance to elderly and disabled people, and they should not be homeless and destitute in the richest country on earth. We should be able to provide a basic income for them. And if we did that, we would pick up, as I said, about 70% of the homeless population would qualify potentially.
And on that note, because we need to wrap up this part of the session, we have a new government in place. They're very committed to prevention. So in practical terms, what would be your advice in terms of the things in the new strategy that should be prioritized, the shared outcomes across government, and in particular bearing in mind the role you played in the development of Finland's strategy, where we know that knowing what works is really key, but so is political leadership. What would be your word of wisdom to the PM?
Well, I think that basic, what we would call safety net assistance, is number one. And ultimately, we would say our problem is not just housing supply, it's income. Homelessness is an income problem. And it's actually the easiest thing to fix as well, because you're just writing checks or bigger checks than you might have. So timely, basic income is pretty much the most important prevention thing you have. And then having emergency assistance, of course, another cash-based emergency assistance because crises happen. And sometimes having your basic income isn't going to be enough to tide you over on a crisis. So having basic emergency cash assistance would be the other thing. And then I guess the third thing I would say is focus on those social welfare institutions that people who are experiencing a lot of difficulties in their lives, they're in these places, we know when they come out. So people coming out of detox, people coming out of jail, people coming out of hospitals. These are places where we could have good social work that's assessing folks, what's their risk, and making their transition back to the community more smooth and make that work. I think if you did those 3 things, you'd go as far as you can, I think, with prevention and homelessness in what I think would be a politically feasible way.
Fantastic. Thank you so much,
You're
Dennis.
welcome. All right, thank you.